Can you again show Sanket? This is Senthil's
So this is not
presentation.
my PPT, sir.
Very good.
Just
Just
minutes,
run till the slide as a trial. Sanket,
Yes, sir. Sir, that
do you
was
have
not
any
my PPT,
challenges?
sir.
Take your friend's help.
Yes, sir. I'm doing that, sir.
Okay. You have other laptop or something to log in?
Just a minute, I'll do it, sir.
Yes. Mutukmar sir, with your permission, if can we have the thyroid case a second case, sir? Because he looks like he is having a challenge. I
No
wish you
issue,
can
sir.
stay back for the obstructive jaundice also, sir. Sorry
Yes, sir.
for
No
asking
issue.
you this.
No issue, sir. No
Senthil,
issue.
thank you, sir. Senthil, can you try sharing your PowerPoint? Jalal sir, good evening, sir.
Good evening. Good evening.
Sir, still in the college, sir?
No, it's my room.
Okay. Dean sitting in the
Good
college,
evening,
do
sir.
you know?
Good evening, sir. Dr. Sandhu.
Friends, I'm going to mute all of you. Faculty and students alone unmute and speak. Sorry. Sanket, you are seen well now. Unmute yourself. Friends, warm welcome to you. We have a galaxy of faculty today. Professor Muthukumar sir is a senior endocrine surgery professor from Madurai Medical College. Professor Vaibhav, again HOD General Surgery at MLN Medical College, Prayagraj. Malarvedi ma'am, Professor of Surgery at Government General Hospital, Rajiv Gandhi Government General Hospital, Madras Medical College. Professor Rajshekhar Mogan from AIMS is expected to join a bit later. Professor Jishan ma'am, Professor of Surgery and past former HOD at Assam Medical College, Dibrugarh. Professor Ramani ma'am should be expected shortly. And I think Kamlesh is going to be joining for the second case. So without much ado, we have the presentation which was not done last week by the candidate for technical reasons. That will go second. I thank Professor Praveen Suryavanshi sir and Professor Bhaskar Musande sir, the HOD at the MGM Medical College, Chhatrapati Sambhaji Nagar, for kindly permitting their student to present a case here. Welcome Ganesh sir from Vellore Medical College. Thank you for joining us today. Dr. Sanket Agarwal will be presenting a case of thyroid nodule. Sanket, kindly share your PowerPoint and start your presentation. Faculty, please take care.
Good evening, everyone.
Ramani ma'am, good evening. Ramani ma'am is professor and head of the department at the Government Medical College at Vizianagaram. Welcome ma'am.
Good evening, sir. Thank you, sir. Thank you for that.
You're good to go, Kana. Make it full screen and start your presentation. Make it slideshow, Sanket.
Yes, sir. Sir, am I audible and visible?
You are perfectly audible, but the slides still remain in the this mode.
Just a minute, sir.
No worries if you find difficult, just retain in this mode. Could see Ganesh sir joining. Srinivasan sir, good evening, sir.
Good evening, sir.
Sanket, just minimize this. Yes. What is happening, Sanket? You have any challenges?
Sir, am I visible now?
Yes. Just listen to me, do what I say. Just minimize this window.
Okay,
On
sir.
the right top, minimize. Yes. Open the PowerPoint.
So yes, I did.
All right. So you please unshare now. You tell me what I'm going to tell you. Unshared. Stop sharing.
Stop sharing. Okay, done, sir.
All right. Minimize all the windows or close all the windows except Zoom and PowerPoint. Bhaskar sir, good evening, sir.
Done, sir.
Done, no? Now
Done,
press
sir.
share screen.
Yes, sir.
What are you getting? Can you, you just read what are the
Entire screen
options you're
windows.
getting?
Chrome tab, windows, and entire screen.
Entire screen, press that.
Okay. Share. Did, sir.
Yes. Now open the PowerPoint. Now your right corner, you have a screen show mode. Yeah, press the slideshow mode. Yes, good to go. Sorry, faculty, for making
Yes,
you
sir.
wait. For convenience reasons, I've grouped the faculty for separate cases, but I've requested Muthukumar sir to stay back for the obstructive jaundice also. I think till Dr. Rajshekhar and others come in, faculty, please take over. Good luck to you, Dr. Sanket. Please introduce
Thank you so
yourself,
much, sir.
your head of the department, and start your presentation.
Yes.
Faculty, please take
Uh,
over.
Good evening, everyone. Myself, Dr. Sanket Agrawal. I am a junior resident at MGM Medical College, Sambhajinagar, Maharashtra. And my guide is Dr. Bhaskar Musande, sir. He is the head of the Department of General Surgery of MGM Medical College. Today, I'll be presenting a case on thyroid swelling. Chief complaints. So, shall I start?
Oh, yes.
Chief complaints. A 43-year-old male resident of Bede, an auto driver, came to the OPD with complaints of swelling over right side of the neck since 6 months. History of presenting illness. Patient was apparently all right 6 months back when he noticed the swelling over right side of the neck. Swelling was insidious in onset, gradually progressive in size in the last 6 months. Initially of size of approximately 2 into 1 centimeter to a current size of about 4 into 3 centimeter. There is no history of pain over the swelling, no history of fever, no history of cough, no history of change in voice, no history of difficulty in swallowing. There is no history of breathlessness, no history of sudden increase in size, no history of any radiation exposure in the past, no history of increase or decrease in the appetite or weight gain and weight loss, no history of chest pain, palpitations, tremors, no history of excessive sweating, no history of heat or cold intolerance, and no history of any other swelling seen. Past history, patient has no comorbidities. There is no history of any past surgeries and no history of any medication intakes, any antithyroid drugs or goitrogens. Personal history, diet is mixed. He consumed mixed diet. Appetite is normal. Sleep is adequate. Bowel bladder habits are normal. No history of any substance abuse. Family history, there is no history of any thyroid disease in the family. Hello. Hello.
Please go ahead, ma. Please go ahead. Till the faculty ask you to stop,
Okay.
please go ahead.
Okay.
Sir,
General,
do we ask questions now
Please,
or
sir, please, sir, please,
at the
please.
end? Okay, as Dr. Shankat, you are talking something about the pain, right? Just go back 2
yes, sir.
slides. Go back 2 slides. So when do you get pain over the swelling in thyroid?
Sir, any inflammatory condition, such as thyroiditis, might cause pain.
Okay.
Any other infective condition, if infected thyroglossal cyst or any infective condition that might cause pain.
How
So
common is infection in thyroid?
so
How many cases of
what
infection you have seen in thyroid?
so two or three cases.
2 or 3 you have seen.
Yes, sir.
As a resident, seeing 2 or 3 is, I think it's a big number. So why it is so rare? Why infection in thyroid is rare?
So because thyroid has first of all rich blood supply.
Very good.
Second, it has iodine. So these are the protective mechanisms which avoid early infection or infection in the thyroid gland.
It also has a tough capsule around it. So
Yes, sir. It's a tough capsule around it.
that's the reason. So you said pain one, you said thyroiditis, then you said infection. Where else? What is the other most common thing where you get pain in thyroid, acute pain?
So if there is hemorrhage,
Yeah, very
if there
good.
is hematomer hemorrhage, then there will be stretch of the capsule which might lead to the pain.
So you're talking something about fever. When do you get fever in thyroid?
So again, any infective conditions. I just asked this history to rule out mainly uh, in decurulent thyroiditis. If we see, so patient might have history of fever, viral infection, which might lead to fever.
Okay.
Hello.
So you are talking something
Yes.
about the breathlessness. When do you get breathlessness?
Sir, if there is enlarged thyroid swelling, that might cause compressive symptoms. In that, he might present with breathlessness, and in metastasis also, if there is
So
any. Uh,
1 minute. Huge thyroid, benign huge thyroid directly causing breathlessness is something very rare. So can you just
okay, sir.
come out with the most common, too rare?
So in malignancy, if there are metastasis in the lungs, then he might have complaints of breathlessness also.
Which malignancy? What metastasis?
So
Thyroid
in
malignancy.
sorry, sir.
Which malignancy I'm asking? Thyroid, you have 3 or 4 malignancies. So what kind
Yes,
of
sir.
malignancies?
So in follicular carcinoma thyroid, there might be metastasis in anaplastic carcinoma. There might be metastasis to the lungs.
Okay. In differentiated thyroid carcinoma, it will be a micrometastasis and causing micrometastasis causing breathlessness is really very, very rare. Okay. So
Okay, sir.
come with other causes of breathlessness. First, what are the causes? Benign causes of benign thyroid when you get breathlessness, then malignancy when you get breathlessness.
So in benign cases, if again there are compressive symptoms, so there we can see breathlessness.
So when do you get
Then
compression? When do you get compression breath in benign?
so
In retrosternal goiters, right?
retrosternal goiter, yes, in retrosternal
Retrosternal
goiter, yes,
goiters are one of the most common of benign causes of breathlessness.
breathlessness, yes.
Where else you get breathlessness? In malignancies.
Uh, so malignancy, anaplastic carcinoma, if they have lung mets, and then
See, why do you want to go always to the metastasis? What about the primary?
oh yes, sir, primary lung cancer, yes, sir, that might be the cause.
See, primary malignancy, it can directly infiltrate into the trachea, or in a
Yes,
differentiated thyroid carcinoma, you can get infiltration into the bilateral acrolaryngeal nerve. If there is a bilateral
yes,
acrolaryngeal, what happens? You get stridor, right?
yes, sir.
So you don't always talk about the metastasis part. Always talk about the primary. Then where else
Okay,
you
sir.
get metastasis? Any functional part where you get breathlessness?
Functional part.
Thyroid, you have hypothyroidism. You have hypothyroidism.
Yes, sir, in hyperthyroidism, the we no, so sorry, sir.
Yeah, of course, you're right.
In hyperthyroidism, we can see breathlessness.
Yeah, that's
If
all. So why you want to
yes,
drag on? So the next
okay.
slide. Next slide. Okay, so you were talking something about the family history. So
Yes, sir.
what do you mean by no history of thyroid disease? What did you ask the patient? So what was in your mind?
So,
Okay, if
uh,
there is a family history, what all you will say?
so I'll look for if there is any family history. So there might be a history of Men's syndrome that we can it can help us to help in diagnosing Men's syndrome if there is any
Okay,
family.
one is Men's syndrome. Next one.
Yes, sir.
Next one.
Then medullary carcinoma thyroid, that again Men's syndrome again,
Yeah, that's what
and
you're talking about.
yes, sir. Other than that,
More commonly, these are very rare.
mm, so, family history, from family history, we can also identify if the patient, if iodine deficiency goiter is uh, there in the family, if he comes from a locality where there is iodine deficiency.
One is endemic
So,
goiters, right? You want to say it's
yes, sir.
endemic goiter. Okay,
Yes,
the
sir.
next thing, what else you can get in family history? If a thyroid
Uh,
runs in family, you're swelling, some 3 or 4 siblings, everyone has a big goiter, huge goiter, soft, big goiters. What else will come into your mind?
so, follic,
Since childhood,
follicular,
no.
men,
Something is deficient in the
iodine
family.
deficiency.
No.
Mm,
Any enzyme?
Red, any enzyme.
What is pendant
Peroxidase enzyme.
syndrome?
Thyroperoxidase.
Hmm.
Dysharmonogenic goitis. To put it in simple words, dysharmonogenic goitis runs in
Yes, sir.
family.
Disharmonogenic. Yes, sir.
So these are the reasons why you ask about this thing, right? And regarding your drug history, you are talking only you told only about the anti-thyroid drugs. You should also talk about thyroxine as well, right? Patient can be
Okay, sir.
hypothyroid. They could have taken thyroxine as well. Okay.
Okay, sir. So shall I proceed?
So with the history, what is your diagnosis?
Ma'am, looking over the history, my patient is a case of swelling in the neck. Probably it might be a thyroid swelling. Furthermore, we have to go for detailed examination for confirmation. But on the basis of history, I suspect it to be a thyroid swelling.
That's all. Do you have any
So he's
toxic
a male.
symptoms? Any toxic symptoms? Any
No, ma'am, there are
complaint?
no toxic symptoms. No,
So
ma'am.
that also
I
you
have
should
mentioned it.
include. No
Ma'am, I have
metastatic
mentioned it.
symptoms? But conclusion, right?
So
Okay,
what
okay.
else do you suspect in such a case? A male patient coming with thyroid. So what do you think it is?
Ma'am, generally, if a male patient present with thyroid swelling, so there are more chances, higher chances of it being a malignant swelling if
Who
we
else?
suspect for a thyroid.
Okay, so a male patient, and who else has a higher chance of malignancy? What other history can point towards malignancy?
In my history, ma'am,
No, generally in history taking, what are the pointers for malignancy or the red
if a
flags?
patient, okay, ma'am, if
The
a
male
patient
patient, what else?
young age group, a young age
Extremes of
male,
age.
extremes of age, yes, extremes of age, then male
Yeah.
patient,
Okay.
then large swelling, if it is hard swelling.
No, just from history.
Acha, just from history, then if he presents with compressive symptoms, ma'am,
Yes, very good. Compressive
then
symptoms like what?
like ma'am, dysphagia, dyspnea, stridor, hoarseness of voice,
What is the dysphagia? What do you mean by
What of-
dysphagia?
so difficulty in swallowing.
So how thyroid produces a difficulty in swallowing?
So it will compress
Which part
trachea
of
and
the
esophagus.
which phase of the deglutition it will affect? Or what are the phases of deglutition? And what is the relationship of your pharyngeal apparatus to the thyroid? Is it just posterior to it?
Sorry, sir, you're not audible, sir, properly.
Is it posterior to your thyroid? And how it is going to compress? Is that what is the relationship of thyroid to the pharynx or the esophagus?
So through Bary's ligament, thyroid is attached to the cricothyroid
Berry's ligament
fascia.
we are not talking about Berry's ligament. We are talking about the thyroid only. You said it is going to produce dysphagia.
Very good.
Yes, sir.
Immediately posterior to thyroid, you are going to have a trachea.
Trachea.
Or the larynx. So once somebody compress on the trachea, again, can it go and compress on the esophagus?
No sides.
First, you must know there are three phases of that: oral phase, pharyngeal phase, and esophageal phase, and which phase it is going to affect. And normally, it is not the way directly it is going to compress unless it is you have a Hashimoto's lesions which can go laterally. It is a posterior lateral compression is a possibility, but it is very, very rare. It is not that just because of the swelling which can produce. And similarly, you said recurrent laryngeal palsy will produce breathlessness. Why it
No,
produces?
sir, I told hoarseness of voice.
Why it
And
produces
breathlessness.
Why it produces hoarseness of voice?
Sir, recurrent laryngeal nerve, if a मतलब recurrent laryngeal nerve, if it is affected, then the function of recurrent laryngeal nerve will.
What will be happen? What is the supply of recurrent laryngeal nerve to the larynx?
So it supplies vocal cord.
Supplies vocal cord.
What are the muscles?
It leaving cricothyroid, it supplies all the muscles of the larynx and vocal cord, mainly
There are
posterior.
two important muscles: adductors and abductors.
Yes, sir.
Both are supplied by recurrent nerve.
Yes, sir, except cricothyroid muscle.
Okay, then why it produces your problem? If you are having an adductor and abductor are equally affected, it should not produce.
Okay, sir. But sir, the adductor muscle, cricothyroid muscle is also supplied by external laryngeal nerve. So if recurrent laryngeal nerve is
Cricothyroid is an
affected,
adductor.
sorry, sir.
Cricothyroid is an adductor muscle.
So yes, sir, it is a
You
abductor muscle.
are okay. There are different reasons. You must know what is Siemens law. Though it supplies both abductors and adductors, so the abductors will be affected more, not the adductors, first for the various
Okay.
reasons. So the first
Okay,
only the abductors is going to that. That is why it is good. So don't just simply say that the thyroid is going to produce infiltration, the recurrent nerve, and it is produced here. Voice change. What are the other voice change you can expect?
So change in pitch of the voice if external laryngeal nerve is any time affected or injured, then
Change in pitch. What do you mean by that? How do you ask that question to the patient? What is
so we ask the patient to speak loudly and through which we can examine the pitch of the voice.
you can, even with the low pitch, you can speak loudly. No? A bass voice can be also loud.
Yes, sir. Sorry, sir, I don't know.
Unless the patient can sing high pitch voice, that soprano or suprabhadam sings his high pitch voice, that there will be a small affection will be there. Invariably, it is again a questionable one, but still you can say there is a muffling of the voice, which
timbre of
normally
the
the patient was able to speak in a louder voice.
timbre of the
Okay.
voice is lost. It will.
Lost. Yeah.
That is
Timbre.
it. The depth of the
Okay.
voice is lost. It will become squeaky and high pitched.
Husky.
Okay,
What is
Sanjay.
the
So
hot
how
potato
does
voice?
this nerve get the name recurrent laryngeal? Now, why do we call it recurrent? And can it be non-recurrent?
Yes, sir. The nerves called recurrent laryngeal nerve because it turn over on the left and right side. On left side over the arch of aorta and on right side over the subclavian vessels. That's why it has given the name recurrent laryngeal nerve.
So
And
now, what is the non-recurrent laryngeal nerve, and what is the problem with this?
so non-recurrent laryngeal nerve is we can see non-recurrent laryngeal nerve in 2 to 3% of the patients. When subclavian subclavian artery directly arises from arch of aorta instead of brachiocephalic trunk, there might be we have non-recurrent laryngeal nerve, and it has a short. Yes, that at that
In
time we
that,
can
the
have.
chances of injury are more because that has an
Yes,
anomalous fact, right?
yes, that is anomaly. So there
Now,
are
in
chances.
history, you have said that history of radiation exposure in the past. So, what sort of radiation exposure have you inquired about?
So I have asked about any disease, any diseases such as lymphoma or any other disease which might for which he might have taken radiation in the past, in childhood or in adolescence age.
Then you have written no history of chest pain, palpitation, on tremors. So, how do you test for tremors in a patient? Thyroid
So
disease.
first of all, we'll ask the patient to close the eyes and we'll ask the patient to extend his both the arms straight, and then we'll keep paper over the hand, and with the closed eyes we'll watch over the paper. If the paper is moving, then it is a test for identifying if the patient is having tremors or not.
Okay, so
Why
Fine
do you want
tremors.
to have such a complicated testing procedure? Even you can't observe, a doctor cannot observe, he needs to put a paper on that. Then how can a patient will know that whether he has a tremor or not?
So
What do you mean by tremor?
so moving, the patient might complain of when he holds the glass is the spillage of water while holding the glass.
Holding the glass, is it a fine tremor? What kind
No,
of
sir,
tremor you get in thyroid?
fine tremor, sir.
So holding the glass, is it a fine tremor?
No, sir.
Can you relate to that kind of tremor to anything else which is normally happen in our life? When you come
So
for the
holding a pen,
examination, what will happen?
holding a pen,
No, again, that is you are putting
writing.
on exercise. No, that is not
Yes.
that fine tremor we are taking. When you are coming for the examination or coming for the, what will happen to you?
So we'll be
When you have
nervous.
anxiety, when you are exaggerated. So it is
Yeah,
only a
anxiety.
physiological tremor, exaggerated physiological tremor. What is the difference between fine tremor and coarse tremor?
So fine tremors are just a minute.
Okay.
So the main difference between fine tremors are of small amplitude. We can see it in high anxiety and stress.
Low amplitude and high frequency you'll be having. Frequency will be more, amplitude will be less.
Frequency, sorry,
Coarse tremor,
low.
the difference in high amplitude. So
So
since
shall
it is
we
very
go
low
for
amplitude,
examination, sir? Already half an hour passed.
yeah.
Examination part.
Okay.
Sanket,
Then
while you're changing the slides, I'd just like to point out one thing that has caught my eye. You have
yes, ma'am.
had a long list of negative history, isn't it? So
Yes,
it
ma'am.
is all mixed up. Suppose you club them, like these are the points that will help me to rule out malignancy. These are the points that will help me to rule out thyrotoxicosis. I think it will bring in more clarity. Okay,
Okay, ma'am.
so let's
Yes,
go to
ma'am.
your examination.
Thank
Or
you, ma'am.
simply in words, you could have said that there are no signs suggestive of hypothyroidism or hyperthyroidism.
Yes.
Okay, sir. Okay, sir. I'll change it. General examination. Patient was examined in well-lit room with adequate exposure in sitting position with due consent. Patient is conscious, cooperative, well-oriented with time, place, and person. Patient is well-nourished, moderately built. BMI 26 kgs per meter square. Vitals are pulse rate is 96 beats per minute, regularly than normal volume. Blood pressure is 130 by 80 millimeters of mercury, measured in right arm with patient in sitting position. Respiratory rate is 15 cycles per minute. Room saturation in room air is 99%. Temperature is 98.5 degree. There are no signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, no eye signs, no tremors. Local examination, inspection, single oval shaped swelling of size 4 into 3 centimeter over right side of the neck, extending superiorly about 1 centimeter below the thyroid cartilage, inferiorly about 2 centimeter above the sternal notch, medially up to midline, and laterally touching anterior border of the sternocleidomastoid. All borders are visible. Swelling has smooth surface with well-defined margins. Skin over the swelling is normal. Swelling moves with deglutition. No other swelling visible. Trachea is in midline. No redness, scar, sinuses visible over the swelling. Palpation. All inspector findings are confirmed on palpation. No local rise of temperature. No tenderness. Single oval shaped swelling of size 4 into 3 centimeter over sorry over right side of the neck, firm in consistency. All borders palpable, regular, which is freely mobile from side to side. Skin of the swelling is normal. Trachea is in midline. Bilateral carotid pulse felt. On percussion, dull note is heard over the swelling. Auscultation, no bruit felt over the swelling. Systemic examination, CVS examination, S1, S2 is heard, no added sounds. Patient is conscious oriented with no non-distended abdomen, soft, no non-tender, and air entry is equal in both the lungs. My provisional diagnosis is 46-year-old male is a case of solitary thyroid nodule in right lobe of the thyroid in a euthyroid state.
In general examination, what are the other thyroid stigmata you will specifically look for? Other than your pallor, icterus, generalized lymphadenopathy, what will you look for?
Ma'am, eye
Head-to-foot
signs.
examination, in other words. Okay, suppose patient is hypothyroid, suppose patient is hyperthyroid. In both scenarios, what are the things you look for from head-to-foot examination?
So, ma'am, in hypothyroid patient might have thinning of hairs, loss of hairs.
Okay.
And then patient will be dull looking, lethargic, and then there will be the weight gain if patient would be fatty patient on this inspection, and then dry skin, patient will have a dry skin,
Okay.
and
Don't you see facial puffiness?
What is this
sorry, ma'am?
Mask-like faces.
Yeah, we might see that. Yes, ma'am. In
Okay.
hypothyroidism.
Okay.
Pretibial
What else?
myxedema? What is this? Pretibial myxedema.
Ma'am, in pretibial myxedema, we generally see this condition in Graves' disease. There, there is accumulation of glycosaminoglycans, which in the lower limb, over the anterior surface of tibia, which leads to bilateral lower limb edema with myxomatous degeneration, mucoid-like material collection.
Okay.
And yes, ma'am.
What about clubbing? You said what clubbing do you expect? What is it called specifically in thyroid diseases?
Ma'am, acropathy, Graves'
Thyroid
acropathy,
acropathy. Okay.
thyroid acropathy.
Okay.
Yes, ma'am.
So when do you get, other than this, when do you get pedal edema? Other than
No.
you're talking something about pretibial myxedema, other than that, when do you get pedal edema?
So if in pretibial myxedema 1, and then
There are two causes.
so in hypothyroidism, there might be we might see edema,
Yes.
non-pitting edema in hypothyroidism.
In hyperthyroidism also, if you have a cardiac failure, again the patient can present with the pedal edema, right?
Yes, sir. In cardiacally, yes, sir.
When do you get jaundice, ictus in thyroid? Normal. Not
Jaundice
directly.
So in
ictus. When do you get ictus? Any medications can cause ictus? Thyroid medications?
so in yes, hepatotoxic medications might cause.
What is hepatotoxic medication? You know, what do you use in thyroid? Thyroid, there are only 3 or 4 medicines, right?
Yes, sir.
Thyroxine, which cause nothing. You have,
No,
what else you have? What else you have?
Then we have carbimazole, methimazole,
Yes.
and propylthiouracil,
Yeah.
and
So all these can cause jaundice.
jaundice.
Right? Carbimazole can cause a cholestatic jaundice, which is reversible.
Yes,
Propylthiouracil can cause even a fulminant hepatic failure. That is the reason why we don't routinely use propylthiouracil and we use routinely carbimazole. Okay,
yes,
because that's an irreversible. Right. Okay.
What will be the blood pressure like in Graves' disease?
So in ma'am, in Graves' disease, in Graves' disease, patients will have hypertension. Blood pressure will be more in the Graves' disease.
More specific, what is increased, what is decreased, what is widened?
Ma'am, there is isolated systolic hypertension in Graves' disease, and there is isolated systolic hypertension in Graves' disease.
So low
With wide
diastolic,
pulse
high
pressure.
systolic, widen
With
pulse
wide pulse
pressure.
pressure. Yes.
So it's a collapsing pulse, hyperdynamic pulse.
Yes.
Yes. Okay.
What is the commonest arrhythmia you will find in thyroid diseases? All arrhythmias are common, but which is the commonest you come across?
Ma'am, atrial fibrillation is the commonest arrhythmia.
What's the most common rhythm abnormality in hyperthyroidism?
Sorry, sir?
Rhythm abnormality in hyperthyroidism, most common.
Irregular pulse.
Just
Sorry, sir, I don't know.
Just tachycardia. That's the most common.
Tachycardia.
There you shouldn't say atrial fibrillation. That's why I asked this question, right?
Okay.
Madam was specifically asking what arrhythmias, then you can say AF. But if it's the most common rhythm abnormality, it is always generalized.
Tachycardia.
Yes.
So what is your anatomical diagnosis after your examination? And
Sorry, ma'am?
physiological?
My anatomical diagnosis, ma'am, it is a case of after examination, it is a case of solitary thyroid nodule. Then for further
Which lobe?
sorry, it is a case of solitary thyroid nodule of right lobe of thyroid. In
From
euthyroid
which
state.
lobe? Right, left?
Ma'am, right. From right
Right
lobe.
lobe. And your physiological? Euthyroid
In
state.
euthyroid state, yes, ma'am. I mentioned.
Pathologically, what are
Euthyroid
you
state.
thinking of? The cause of the enlargement of. What is the most
Ma'am,
common cause of a solitary nodule in thyroid pathologically? And what are you contemplating here?
generally, most common cause of solitary thyroid nodule is multinodular goiter.
Oh, that is the last. Dominant nodule of a multinodular goiter is the last option you take.
Okay. Ma'am, adenoma follicular colloid nodule is the commonest swelling.
Okay. Then other ones?
Then other than that, follicular adenoma might be there. Then thyroglossal
That is
cyst.
follicular adenoma. First you told follicular adenoma.
Yes, ma'am.
This is not
Then
first. That is second. Another one?
okay. Colloid nodule.
Wow, very good. Colloid cyst or
Colloid
colloid
cyst.
nodule. Other? Being a male, what do you think? Your third diagnosis. Maybe the first diagnosis.
Malignancy follicular.
Thyroid. So
Yes,
these
ma'am.
three options you have now. How do you confirm? You already know no pressure symptoms, no toxic symptoms, and then
Yes,
no malignancy symptoms also, because you have ruled out any lymph nodes. What
yes,
is thyroid paradox?
Ma'am, thyroid paradox is when there is cellular swelling, cellular content, the swelling will be soft, and in cystic content, the swelling will be hard or firm.
Okay. So, in other words, soft swellings are not benign, hard swellings are not malignant. Why not they malignant? Hard swellings are not malignant in thyroid, and soft swellings are not benign in thyroid. Can you explain with some examples?
Ma'am, in Hashimoto's thyroiditis, it has a hard swelling. For example, if Hashimoto's thyroiditis, it is a hard swelling, but it is a benign condition.
Hashimoto's, we don't say it's hard, right? It's more of a firm in nature.
Firm or hard?
Of thyroid, you have stony hard swelling. Now, what is it? Madam is asking that.
Sorry, sir?
The swelling is stony hard, yet it is a benign swelling.
Sir, Riddle's thyroiditis.
Riddle's thyroiditis, right.
Any other long-standing
confused with malignancy.
Shows some hard areas. Long-standing.
Long-standing.
I gave you half diagnosis.
Long-standing goiter, multinodular goiter.
Multinodular goiter. Sometimes some areas may feel hard. Why?
Ma'am, because of deposition of colloid in the nodule, formation of colloid nodule.
It will be soft. Colloid will be soft. Something is degeneration has occurred. Some degeneration.
Calcification.
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 What do you call that calcification?
Fibrosis in the gland. Fibrosis in the follicle. Calcification.
Dystrophic calcification.
It's a dystrophic, yes, dystrophic calcification.
So why did you percuss on the swelling? What is the purpose of percussion over the swelling on the thyroid? What do you get? Do you get some node? Do you get resonant node in thyroid?
Some other areas you should focus, not on the neck. We don't.
Yes, ma'am. We focus on the sternum to rule out if there is any retrosternal goiter.
But not on the swelling. It is very much discomfort for the patient and no information for you. Right?
Okay. Yes,
please don't mention the percussion over the swelling in thyroid.
You should
Okay.
not
Okay, sir.
percuss, right? And bruit is heard, thrill is felt,
Okay. Oh, yes. Brew is heard, thrill is heard. Okay.
right? So
So
when
it
do you
might
feel the
be
bruit, or when do you hear the bruit? Which place or thrill?
superior lobe of thyroid. We hear the bruit because of superior thyroid
Ah,
artery, increased
okay.
vascular.
Okay. So now you have three. Your diagnosis is altered thyroid nodule, and then how
Yes,
do you
ma'am. Mm.
proceed now? Non-toxic, non-neoplastic.
Yes, ma'am.
So Vaibhav,
Further
sir,
which,
please
ma'am,
carry on. I just,
Yeah.
I
So
came.
what will be the algorithm which you will be following now?
first of all, sir, I'll proceed with now. As I know my patient is euthyroid state, I'll go for blood investigations associated with USG along with ultrasound guidance. USG for thyroid scoring.
In blood
Uh,
investigation, which investigation will you like to do? If you are asked to do one thyroid test, which will you go for?
Sir, I will go for TSH.
TSH. Okay. And what is the indication for scanning in a case of thyroid swelling? Radionuclide scanning, what is the indication?
So if TSH is low, it means कि gland is in it is producing more hormone. So to rule out if there is any hot nodule, cold nodule, or what is the condition of the gland, we go for a radioactive iodine scan.
So the only indication is toxicity with
Toxic
nodularity.
adenoma.
You want
Yes.
to know whether it is a
Toxicity with
multi-nodule
nodularity.
which is
Yes,
producing
ma'am.
toxicity or it is
That
an autonomous nodule.
Toxic adenoma. Yes, autonomous
Which
toxic nodule.
isotope do you use for scanning?
Sorry, sir.
Which isotope do you use for scanning of thyroid?
So we can use isotope 123, iodine 123, and iodine 131 in low dose.
When is iodine 131 used and why?
So iodine 131 will helps us to look for the uptake and organification of the gland. So if we go for a diagnostic purpose, we'll use in low dose about 2 to 3 microcurie for diagnostic purpose.
What is stunning effect?
Ma'am, when we use iodine 131 for diagnostic purpose, it might damage the gland, damage the follicles, which will lead to inadequate result from the scan, as the damaged part won't uptake, won't take up the iodine, so that will lead to false.
That is why when you are contemplating a malignancy, you should not give iodine preoperatively for any evaluation because you may need
Yes,
it for ablation later on.
ablation, yes, ma'am.
CT scan also you should not do with an iodine
Iodine
contrast.
contrast, yes,
So
ma'am.
what is thyroids? What do
Ma'am,
you look at?
we look for 5 components in thyroids. First of all, we look for shape. It has 2 components, wider than taller and taller than wider. It has given points for 0 and 3. Then it has uh, uh, then we look for echogenicity. Echogenicity is hyperechoic. Sorry, anechoic. Hyperechoic is 0, anechoic or hyperechoic 1. Then hypoechoic and very hypoechoic. And then
How much score for very hypoechoic and
then
hypoechoic?
very hypoechoic 2. Hyperechoic is 0. Iso or hyperechoic is 1. Very hypoechoic is 2, and very hypoechoic is 3.
Anechoic?
Anechoic is 0, ma'am. First.
Right. What else?
Then we go for composition, ma'am. Composition, it might have cystic component which has 0 point. Then spongiform component which also has 0 point. Then mixed cystic and solid which has 1 point, and solid component it has 2 points.
Solid
Other than that, ma'am, mixed solid and cystic it has 1 point.
Okay. What else you'll see?
Then shape, then margins, we will look for margins. Smooth margin will have 0, ill-defined margin 0, then lobulated,
Let's tell the highest
extrathyroid
malignancy.
extension 3, extrathyroid extension 3 points.
Then
And echogenic foci, it will have
okay, next.
punctate echogenic foci 3 points. Then from which we will find out the score, and thyroids have 5 categories. Score 0 is 1, thyroid 1, which is a benign.
Okay, done. Okay, okay. Now, what else you'll do?
Ma'am,
What
then
you have done? When do you don't do anything? No treatment. For which score? No treatment only and only observation.
ma'am, 0 and up to 2 score we go for observation, and after 3, if size is more than
Suppose the score is high, what you'll do?
ma'am, I will proceed with FNAC in this case.
Anything more along with FNAC? Do you want to do something to increase your yield? You want to guide
USG guided FNAC.
which
USG
area
guided FNAC.
FNAC from?
Sorry,
How will
ma'am?
you decide? From which area you should do take the FNAC?
Ma'am, we take
Very
from
anechoic area, isoechoic area, hypoechoic area. Which area you want to?
ma'am, from hypoechoic area we will take the FNAC.
Yeah. So what is that
Yes.
system? What is the name of the system? Just like thyroid, you'll score. That is also given some points, 1, 2, 3,
And
4, 5.
that is the criteria. That is the criteria.
Okay.
It has 5 components.
Okay. So if this is done, you have this person, you have evaluated his thyroid profile. It is euthyroid, and
Yes, ma'am.
ultrasound is showing hypoechoic with some solid cystic areas. FNAC is some 3 or Bethesda 3 or 4, atypical follicular flasks. What will you do now?
Ma'am, I'll proceed with
Being a male.
I'll proceed with he being a male patient, I'll proceed with hemithyroidectomy with frozen section.
Why?
And if ma'am, as you mentioned it, there is a TPA the on FNAC, it has grade 3 or 4. That means it is a follicular pathology. So for confirmation, we'll go for hemithyroidectomy with the frozen section. If frozen section is suggestive of follicular adenoma, then we might
How will
stop there.
follicular, the malignancy also looks like an adenoma. The same follicle cells are seen. How do you say there's a carcinoma in frozen section or any other?
Ma'am, involvement of basement membrane will be there in follicular carcinoma.
No.
See, there is no role for a frozen section if it's 3 and 4, right? Follicular adenoma and follicular carcinoma can never be judged by a frozen section.
Okay, sir.
So we don't routinely use a frozen section if you want to. It's similar to FNAC. Frozen section, you don't differentiate between a follicular adenoma and a follicular carcinoma. So either you go for a total thyroidectomy, or if it's a PAPSA, then definitely you can get a yield in the frozen section. But follicular, definitely no.
Okay.
You can't get a diagnosis with the frozen section.
Okay.
Okay.
How will you differentiate a follicular carcinoma and a follicular adenoma? How the pathologist will tell you? Seeing what? Not the basement membrane.
Capsular and vascular invasion. No, capsular and vascular invasion. That one line is in it.
Yes. Capsular and vascular.
Capsular and vascular invasion.
Okay.
That cannot be seen in a
true-cut biopsy routine.
That cannot be seen in a frozen section.
Okay.
So FNAC and frozen.
Frozen section is not useful in thyroid malignancy because capsular and vascular invasion cannot be seen because the cells are frozen and the part you take cannot be seen, will not tell. So say one word, capsular and vascular invasion.
Vascular invasion. Okay.
Suppose it came as an adenoma, what you'll do?
Ma'am, if it comes as an adenoma, so we can stop at we can complete our surgery at hemithyroid after removing half of the lobe, hemithyroidectomy.
Okay. Only follow, right? So Sir, carry on.
Yeah, sorry, ma'am. So
Once you
suppose
say
you are doing
hemithyroid,
hemithyroid.
follow.
how much part of thyroid is removed?
Sorry, sir.
Once you say you are doing hemithyroidectomy, so which part of the thyroid will be removed for a right-sided proliferative thyroid nodule?
Sir, right lobe of thyroid with isthmus.
Right lobe with isthmus. Okay. Compared with hemithyroidectomy and total thyroidectomy, what is the advantage of doing a total thyroidectomy?
So, in total thyroidectomy, if we are if the case is of a suspected malignancy or a malignancy, then the recurrence will be very less. Almost, if it is a confined disease, then recurrence will be zero. If we proceed for a total thyroidectomy, in hemithyroidectomy, if there might be chance of recurrence. First, one difference is this: in hemithyroidectomy, in total thyroidectomy, patient will require lifelong thyroxine supplements. In hemithyroidectomy, he will not require lifelong thyroxine supplements. And the recurrence is almost zero that I mentioned earlier.
Suppose for this case, you've done a hemithyroidectomy, okay? And the histopathology turns out to be positive for malignancy. Say it's a PAP-CA or a follicular CA. What do you do?
So we'll proceed for a total thyroidectomy, or if we did a hemithyroidectomy and then we send histopathology, then we can do completion surgery in 7 days or after 3 to 6 weeks.
Yeah. Within 7 days?
Sorry, ma'am?
Yeah. Correct. Carry on.
Within 7 days or after 3 to 6 weeks.
Okay, your swelling size was around 4 cross 3 centimeter. Suppose the swelling is 2 cross 2 centimeter and you are doing a hemithyroidectomy, it turns out to be positive for malignancy.
Yes,
then what will you do? The ultrasound, the other side is normal.
I'll proceed with total thyroidectomy. On histopathology, it is confirmed as malignant, right,
How
sir?
do you classify thyroid malignancies into low risk group and high risk group?
So low risk group, which when the size of the swelling is less than 1 centimeter, there is no capsular invasion, no vascular invasion, no extrathyroid spread. Then these are low risk, and high risk group are when swelling is more than 4 centimeter, then there is capsular invasion, lymph node spreads, extrathyroid extension is present.
One thing you are missing, the sex of the patient. Supposing it's a female patient.
Yes, sir. If it is a male patient, then it comes in a high risk group.
Even the age also.
Age is if there are different scores for that. If age is less than 40, so we consider it low risk, and if more than 40, with high risk in male, and in female less than 50 and more than 50.
So after a total thyroidectomy for carcinoma that you have done, how will you follow?
Ma'am, first of all, we after total thyroidectomy, we'll go for after a histopathology report, we can categorize patient into low risk, intermediate risk, and high risk. Then if patient falls in a low risk group, then we'll just advising follow up with thyroglobulin level after about 3 to 6 weeks.
You won't give something? You'll just leave him like that, thyroglobulin? No, then what you'll give him?
With thyroid supplements, ma'am, L-thyroxine generally we use.
How much you'll give? What is the level, ideal level that TSH should be maintained? How much it should be suppressed?
It should be suppressed to about 0.5 to 2. TSH level should be less than 0.5 to 2 nanogram per
Again, on the grade of the, you graded them, no? So almost 0.1.
Okay.
TSH.
0.5 to 2 is for low risk cases.
Yes, ma'am, for low risk. I was just telling this about low risk.
0.5 to 2 is for low risk. For high risk, as madam said, is less than 0.1, right?
Less than 0.1.
Suppose it comes as high grade, it falls into the high grade, then what do you do?
Thyroglobulin is increasing. What you'll do?
So after that, we'll go for a radioactive iodine scan to look for if they. Sorry, ma'am.
When do you do the scan and what should be the indication? When should you do it? Not the time, something else also.
Ma'am, if
You have to assess something and then you have to go. What is that you have to assess before you take up the patient for the iodine scan?
ma'am, if thyroglobulin levels are more than 2 nanogram per ml, then it signifies there might be.
You're talking about follow-up. Man is not asking
Yes.
about the follow-up. What is the prerequisite for the patient to take iodine? What is the prerequisites? You are talking about thyroglobulin in the follow-up period.
Yes, sir.
Immediate post of thyroglobulin can be 50, 30, 40, whatever it is. You just remove the thyroglobulin will not be less than 2. Okay.
So you want to take up the patient for the metastatic workup. You want to give him radioiodine, but the radioiodine has to be taken up. No, so something has to be at some level for it to be taken. What is that?
TSH should be more than 30.
Yeah.
If you want to go for a radioactive iodine scan.
Okay. I think it's almost 9. Sir, anybody will summarize and we can. Anything more, sir?
No, ma'am. Ma'am, I think we are okay. We normally allow the candidates to ask any questions. Jishal ma'am, Vaibhav sir, and Kanna sir, any other comments, sir?
Yeah, just the parathyroids. One comment on the parathyroids. I think
Yes,
how
ma'am,
you
please.
deal with them. Yeah, how would you deal with them, Sanket? The parathyroids in different cases.
Generally, we preserve parathyroid glands while if it is a low risk, if it has no extensions, no capsular invasion, no extrathyroid extension, then we just can go for thyroidectomy with preserving parathyroid glands.
And if you're
Which parathyroid is always constant?
Sorry, ma'am.
Which parathyroid is always constant in position and which moves?
Ma'am, superior parathyroid glands are always constant in position and inferior.
Shankat, regarding the parathyroid preservation and the grade of malignancy has no relation, right?
Yes,
whatever it is, you have to preserve the parathyroids. There is no other choice. Suppose if you're going to do a central compartmental lymph node dissection and you find parathyroid there, and if you feel that if you're going to take a parathyroid out because of central compartmental dissection, at that time, you can, if it's not feasible to preserve the parathyroid, you take the parathyroid, mince it up, and put it in the stenochleiomastite. Okay.
Yes.
So the grade of malignancy has nothing to do with preservation of parathyroids. Whatever case you're doing, you have to preserve all 4 parathyroids. That's a dictum.
Okay, sir. Yes.
I think we can wind up.
Malar ma'am, Bhaskar sir, your final comment, sir. Unmute, sir.
Overall, a good presentation, Sanket. Only thing in the history, as madam pointed out, you'll have to stick to grouping the symptoms is important. Okay, when you're talking about lots of negatives, no signs of hypo, hyper, no pressure symptoms like that, you'll have to do. And even the like CNS symptoms and CVS symptoms were mixed together. You said chest pain, palpitations, and tremors. So don't do that. So come system wise. Okay. Otherwise, it was a good presentation. Congratulations.
Thank you.
Dr. Sanket, do you have any questions to ask or doubts to be clarified?
No, sir.
Bhaskar sir, you are unmuted. I'm unable to unmute you, sir.
You presented well, Sanket.
Thank you, ma'am.
Thank you, ma'am. Not able to unmute, sir.
Can the host and I think host cannot unmute.
I will find out.
Help us in the
Are you not able to unmute yourself, sir? You are very sad. Anyway, sir, thank you very much for permitting Sanket here. And I think it was a very useful deliberation for both the faculty and the student. And I'm sure we look forward for more presentation from MGM Sambhaji Nagar, sir. Thank you, Muthukumar, sir. Friends, with the permission of the faculty, Sanket, you can stay back for the discussion. Dr. Sendil will be presenting the next case. He is a student from Institute of General Surgery, Madras Medical College. Senthil, please introduce yourself, your unit chief, your director, sir, and then start your presentation.
Good evening, ma'am. Good evening, sir. I'm Dr. Senthil Kumar, third year resident of Madras Medical College, and my mentor is Dr. Durai, and I'm here to present the case of obstructive jaundice, ma'am. Sir, shall I share the slides, sir?
Please start.
Yes. Sir, I'm sharing the PDF since PPT is not. I'm not able to share the PPT.
No problem. You are good to go, ma'am. You are good to go. Good to go. Please move.
Today my presentation is on obstructive jaundice. A 58-year-old gentleman who is a former by occupation resident of Vellore came to general surgery OPD with chief complaints of yellowish discoloration of eyes for past 3 months. History of presenting illness. Patient was apparently normal before 3 months. Then he noticed yellowish discoloration of eyes, which was insidious in the onset, gradually progressed and is not associated with abdominal pain. He has a history of passing clay-colored stools, history of passing high-colored urine, history of itching all over the body, and he has a history of unintentional significant weight loss for about 10 kg since 2 months. He has a history of loss of appetite and a history of upper back pain, and he also has a history of taking native treatment since 3 months. There's no history of abdominal distension, no history of nausea, vomiting, no history of fever, malaise, skin rashes, no history of blood transfusion, no history of tattooing, no history of worms, hematemesis, melena, or other bleeding tendencies, no history of dyspnea, cough, no history of chronic drug intake. Past history, there is no similar history in the past. Yeah, he has developed. Now he has been identified with the type 2 diabetes mellitus for past 1 year, and he's on metformin. Not a known case of hypertension, CAD, CVA, or any other disorder. No history of previous abdominal surgeries. Personal history: he takes a mixed diet. Patient has complaint of decreased appetite. Disturbed sleep pattern is present due to itching. There's a normal bowel and bladder habits. He's a smoker since 25 years of age. Consumes alcohol since 30 years. Family history: there is no cancer-related death in the family or GA malignancy in the family. No history of similar complaints in the family. Treatment history: patient has undergone native treatment for jaundice at Vellore 3 days after the onset of symptom. Discontinued it 1 week back. Summary: 58-year-old male belonging to lower class who is smoker and alcoholic came with complaints of jaundice since 3 months, which is painless progressive with pale colored stools and high colored urine. He also has itching, back pain, and he has developed a type 2 diabetes recently on medication. I would like to have a provisional diagnosis of obstructive jaundice, probably due to malignant etiology, and see a head of pancreas.
Okay.
Sir, shall I proceed, sir? Ma'am?
We'll just discuss the history first.
Yes, ma'am.
Go to the first slide, Senthil. The faculty will take over. Go to the first slide. They will revisit the slides and ask questions.
Okay, sir. Okay.
So who is with me, sir, for this? Dr. Muthukumar is there, sir. Myself.
Madam, you please go ahead, ma'am. We have all the faculty. Musande sir is there, and we have Kanna sir. Muthukumar sir is also there. Professor Ganesh sir is there. Jishan ma'am is there. Everyone is there, ma'am. Please start going. They will join. Vaibhav sir is also there.
Right, sir. Okay. So now you have a diagnosis of an obstructive jaundice. And you also told malignancy and the CA head of pancreas. That is your provisional diagnosis with the history. Can you substantiate why you have derived at this diagnosis with your history?
Yes, ma'am. Patient has a short history of 3 months and the jaundice is painless, progressive in nature, ma'am. And the most common jaundice in case of obstructive jaundice and painless progressive
So
will be.
Why did you think as obstructive jaundice first?
My patient has patient has patient has developed jaundice in short duration, so there has to be some obstruction in the distal part, in the CBD part, ma'am. So the jaundice
Short
must have
duration
developed.
can be even for a viral jaundice, viral hepatitis.
But there's no history of fever, ma'am. Patient doesn't have any history of fever or pain.
Maybe it's a transient fever which the patient might have not noticed.
There is also history of weight loss. There is also history of weight loss. There is also history of.
No. What is there to say that it is a surgical jaundice?
Something
What
is
the
having
triad of
no.
symptoms?
There is some positive things you have kept there.
What are the symptoms to say that it is a surgical jaundice? It's obvious, no? Tell me.
You have listed it out, but you're not saying.
Patient is passing high colored urine and clay colored stools.
Yes.
High colored urine and clay colored stools.
Yes, ma'am.
And
he has itching and jaundice all over. Jaundice and itching.
Just explain why this happened. Why this happens in an obstructive jaundice.
Upper back pain.
Why should there
what
be
are the reasons for clay colored stools?
Usually
tell one by one.
Yes. Yes, ma'am. Usually in enterohepatic circulation, if enterohepatic circulation is happening properly, the stercobilin will give yellow color to the stools, ma'am, and urine will have a normal yellow color because of urobilin. In case of obstructive jaundice, there will be excretion of conjugated bilirubin, which will give high colored urine and clay colored stools, ma'am.
Clay colored stools, why?
Ma'am, because there is loss of stercobilin, and in case of periampullary growth, there will be like silvery kind of stools because steatoria and bleeding will be mixed, which will cause.
The conjugated bilirubin is not entering the GIT; it is blocked.
Yes,
for it to be metabolized to stercobilinogen and urobilinogen. It is just stopped there, and that bilirubin is going into the circulation.
Yes, ma'am.
Yes, okay. That is the cause of this.
Here, can I ask another question here?
Yes, ma'am. Sorry, ma'am.
You have said that the patient had come with jaundice. No other complaint?
Ma'am, patient also
Yes.
he had mild abdominal pain. He also had weight loss, ma'am. As a weight loss and loss of appetite was there, and he also complained of itching, ma'am.
Was the weight loss something that the patient complained to you? In other words, was it one of his chief complaints?
No, ma'am. He was cachexic. When we inquired about the history, he was telling about the weight loss, ma'am.
So he had a single complaint, right?
Yes, ma'am. Yeah,
only
actually,
jaundice?
his complaint was jaundice, ma'am. Yellowish discoloration
only
was the
jaundice. All right.
Yeah, ma'am.
All right.
And itching was there, ma'am.
So you have a jaundice with itching, high colored urine and clay colored stool. You think it is an obstructive jaundice. We still don't know whether it is a malignancy or a benign. But since there is a significant weight loss, it is more towards the malignant. Okay. Can you explain about this pain? What you're talking, the nature of pain to come to a conclusion?
Ma'am, patient complains of dull aching pain, ma'am, actually, and it is not intermittent. Patient complains of in the epigastrium and it's in the lateral left hypochondrium. It's in the epigastrium. And primarily, the patient complains of pain in the epigastrium region, ma'am, and it is vague pain, and it is not like intermittent and high grade pain. It is a vague and continuous kind of pain, ma'am.
So continuous vague pain.
Yes, ma'am.
Okay. Suppose it is in the right hypochondrium. Sir. Carry on.
What is the difference between obstructive jaundice and surgical jaundice?
So in case of surgical jaundice, if we can cure the obstructive jaundice by surgery, then it comes under surgical jaundice. So obstructive jaundice sometimes cannot be cured by surgery. Like patient will be going for palliative treatments. In that case, that is the difference, sir.
Can you give the example of the obstructive jaundice where you will not do the surgery?
So in case of metastasis, if the patient has METs, if in initial evaluation, if we find that patient has METs, then the patient will not go for definitive surgery, sir. He will go for palliation. In that case, we can't cure it by surgery. So it is like obstructive jaundice, which can't be cured by surgery, sir.
No. I think it is because of, you know what is cholestatic jaundice?
Cholestatic jaundice is due to absence of motility. The bile gets stagnated in the gallbladder, sir. So there is a jaundice.
In the gallbladder or somewhere else?
Ma'am, in the gallbladder and liver. Not sure.
Intrahepatic.
Yeah, in cases of hepatitis also, you can get the cholestatic jaundice. So
Okay,
that
sir.
will be obstructive jaundice and not a surgical jaundice.
Yes, sir.
What is acholoric jaundice?
Acholoric jaundice, in case of hemolytic disease, hereditary splenoidosis, the bilirubin will not be conjugated, so it will not be excreted in the urine, sir. So the patient, in spite of having jaundice, will not have any bile excretion in the urine. It is acholoric jaundice, sir.
And can you tell a condition where the urine is yellow but the sclera is not yellow?
Urine is yellow and the sclera is not. So in case of dehydration, so sorry, sir, I don't.
Yes, in dehydration it can occur, yes. Any common drug which everyone almost takes?
Rifampicin, pyrazinamide. I am not sure, sir.
Yeah, rifampicin is the one of the drug which produces orange type of the jaundice, or the orange type of the urine. But the
Yes,
simple
sir.
B complex,
Okay.
everyone takes the B complex. And that
Yes,
can
sir.
cause the colored urine.
Okay, sir.
What is the maximum level of bilirubin which can reach?
Which can hit.
What can be the highest level of bilirubin?
15 milligrams.
If somebody
Sir,
says this, my bilirubin is 200 milligram%, will you accept that or not?
no, sir. 15 to 20 milligram is usually.
Not 15 to 20. 15, 20 is quite low. It's around 35.
Okay,
So
sir.
After that, liver stop secreting that.
Hepatic
There is
failure.
excretion from the GI is there. So all those regions makes that it can never go probably beyond the 35 J.
Okay, sir.
So what is the normal bilirubin level?
Less than 2 grams, ma'am. 2 mg per deciliter.
2 gram.
2 mg per 2 mg, sir.
Normal level. What is the biochemical jaundice? And when will the jaundice be evident? At what level of bilirubin? Clinically, the jaundice.
Yeah, less than 2 mg it will not be evident, ma'am. Like 2 to 3 we can see it in the sclera, and up to 5 we can see in the upper body. More than 5 we can see it in the upper body and lower trunk, ma'am. And more than if it is around 10 to 15 we can see it in the entire body. Body will be yellowish discolored, ma'am.
Then what is biochemical? Only that we have left. What is normal?
Ma'am, less than 1.2. If it is not detected in the clinically, if we see it only in the elevated in the blood parameters, it is biochemical jaundice.
Around between 1 to 2 milligrams. It is biochemical. So beyond 2.5, it will be evident.
Yes.
So less than 1 milligram is the normal level of the bilirubin. Right? You said native treatment for jaundice. What is this?
He has undergone some herbal. He has took some herbal medication for jaundice.
Will it worsen his condition or cure?
No, ma'am, it didn't cure his condition. It didn't worsen also, ma'am.
Okay, so the pain you were saying, the pain. Suppose the pain is in the right. Can you just tell the sites of pain and the causes of this jaundice and the pathology? Can you enumerate? Explain. Suppose it is in the epigastrium, radiating to back. What is the cause?
It could be due to CA head of pancreas or periampli growth involving the retroperitoneal nerves.
So that much we can't say. We can say it is due to pancreas. Suppose it is in the right upper quadrant, right hypochondrium, and in the face of jaundice.
It can be due to cholecystitis, ma'am, or polyleucopolithiasis causing pain. It could be like gallbladder.
Yeah. What is Charcot's triad?
In presence of jaundice, patient will have intermittent pain, intermittent jaundice, and right hypochondrial, intermittent pain, intermittent jaundice, ma'am.
Okay. If two
What
more
is
are added,
Raynaud's pentate?
what two more are added?
What is
Raynaud's
Raynaud's pentate?
pentate.
Raynaud's pentate is with mental confusion and patient will have hypotension.
What does it signify? Hypotension and altered sensorium.
Ma'am, it signifies that severe cholecystitis is there. Patient is undergoing severe cholecystitis. Yes, ma'am.
He is in the coma.
Yes. Yes.
Liver failure almost, right? Okay. Your next slide. So now till now you have told there is an obstruction and there is a jaundice and there is upper back pain.
Yes, ma'am.
Okay. Next, yes, next.
It's a negative history, ma'am. No history of abdominal distension, no history of nausea, vomiting, no history of fever, malaise, no history of blood transfusion, no history of tattooing, no history of worms, no history of hematomesis.
Why did you ask for blood transfusion?
Ma'am, it could be due to hepatitis, blood-related transfusion reaction, or hepatitis can be there, ma'am. Transfusion of hepatitis. So,
when does the jaundice occur after blood transfusion? When it appears?
Within 24 hours, sir. I'm not sure. Sorry, sir.
Within 24 hours, what type of the reason may be there?
What type of, sorry, sir?
Reason for that. Reason for that. If it occurs within 24 hours.
NBU incompatibility because of.
Yeah, because the incompatibility, the hemolysis is there. And if it is because of the viral, then when it will appear?
It will take months, weeks to months to appear, sir. After
about 6 weeks, yeah. Okay.
Why did you ask for worms in stools?
Ma'am, in case of clonarchins infestation, patient will have obstruction in the in case of CVD, ma'am. So patient will have jaundice.
So what is that? What is the Courvoisier's law?
Courvoisier's, in case of obstructive jaundice, if gallbladder is palpable, it is seldom due to stone disease.
Okay. So with the stone, with the worms, what could it be?
Gallbladder will be palpable. Yes, ma'am. Gallbladder will be palpable.
Okay. Okay.
Which other worm is responsible for that? You know, in Jammu and Kashmir area, which is the worm there?
I'm not sure. Ascaris, I'm not sure.
Yeah, Ascaris, yeah. It is Ascariasis. Yeah.
Okay. Proceed with
what
your...
are the exceptions to the Courvoisier's law?
Ma'am, it is double impacted stone and mucosal of the gallbladder, pancreatic calculi are the exceptions of Courvoisier's law.
Okay. Your past history, you said some surgeries. No history of surgeries. What do you have in mind? What surgeries can produce present condition?
Ma'am, in case of abdominal surgery pertaining to hepatobiliary system, if patient has undergone surgery, it can lead to stricture formation, ma'am, which can result in obstructive jaundice in the future.
Right. Then the diabetes mellitus, is it, what is the duration you said?
It's for 1 year, ma'am. Patient complains of recent onset of diabetic mellitus. And
1 year is not recent, no?
Yeah.
For this condition. So we cannot attribute this 1 year jaundice to this, right?
Okay.
Okay. Personal history. What else you have asked?
Diet.
So which personal habits predispose for this condition?
Smoking can predispose to pancreatic malignancy, ma'am. And alcohol, like chronic liver disease. And
how does alcohol produce? Sorry, that's good.
Yeah, disturbed sleep due to itching. So what is the typical abnormality in sleep which you find in a patient of obstructive jaundice?
In case of obstructive jaundice, the patient will have itchy palms and sir, sorry, sir.
We have written specifically due to itching. That's why I'm asking.
Yes, sir.
What happens to sleep in a patient of hepatic failure?
Diet.
Diet, increased protein diet is prone. Patient with increased protein diet will have a risk of developing pancreatic malignancy.
Protein or fatty diet? I think fatty diet. Right. Okay.
Protein, fatty diet.
Okay. So you've answered sir's question, sleep pattern. Did you answer?
Ma'am, I was answering, ma'am. In case of obstructive jaundice, the patient will have itching in the palms and sole, which usually increases at night, ma'am. And because of that, patient will have can have disturbed sleep. Ma'am.
Okay.
What is the typical characteristic of itching which you will find in these patients? Supposing a patient walks to an OPD, so what you will find?
Patient will have itching marks in the abdomen and
you will have blood marks over there in the itching, because of altered coagulation profile as well. And why does itching occur in these patients?
So it is because of a deposition of bile cells and bile pigment in the skin, and it is also said to be because of deposition of bile cells in the thalamus, which is increasing the secretions, and the patient will have histamine secretion, and patient will have itching.
So
what is the difference between itching because of the jaundice and because of the skin problem? In a skin problem, also the patient will have the itching, and
Yes,
jaundice
sir.
patient also will have the itching. What
Skin
is the
problem
difference?
might have erythema kind of features, and there is no diurnal variation in. I'm not sure.
In jaundice patient, there will be bleeding will be there, na? So because of the coagulopathy, while it
Yes,
will
sir.
not there in the skin disease.
Yes, sir.
You go continue with your presentation.
Yes, ma'am. I would like to proceed with the general examination and systemic examination, ma'am. In general examination, patient was conscious, cooperative, and oriented to time, place, and person. So patient was thin built and poorly nourished. BMI was 17.3. His afebrile, hydration was fair. ECOG was 1, ma'am. Vitals, afebrile, pulse 68 beats per minute. Blood pressure was 100, was 98% normal. Patient general examination revealed icterus. Failure can't be commented upon. No clubbing cyanosis, speed edema, generalized lymphadenopathy, no left supraclavicular lymph node. These are the clinical pictures. Patient has scratch mark over the trunk and peripheries, and no signs of chronic liver disease, and no evidence of migratory thrombophlebitis. Per abdomen examination, after getting consent from the patient is examined in a well-lit room. Abdomen appears scaphoid with the umbilicus in the midline and inverted. All quadrants moves proportionally with respiration. A 3 x 2 cm globular mass was seen in the right hypochondrium, moves with respiration with well-defined lower and lateral margins and median margins. There was no visible gastric or intestinal peristalsis, no visible pulsation. Skin over the abdomen is not, scratch marks were present, no scar or dilated veins. Bilateral flanks normal. Hernia orifice, there is no visible cough impulse. External genitalia appears normal. Palpation, patient in supine position with knees flexed and arms by the side of the body. On superficial examination, there was no local rise in temperature or tenderness. A globular mass of 3 x 2 cm was palpable below the lower border of the liver in the gallbladder region, which has smooth surface, firm and consistency with well-defined lower and lateral margins. The upper margin could not be made out by palpation and moves with respiration. And also side to side mobility was present. Mass becomes less prominent on head raising. This was the area where the gallbladder mass was palpated. No other palpable mass, no hepatomegaly, splenomegaly. External genitalia was normal. Hernial orifice and renal angle was normal. Liver span was normal with 12 cm in mid-clavicular line. Dullness over the mass and tympanic over the other areas of the abdomen. There was no shifting dullness. Auscultation, normal bowel sounds was present. Per rectal examination, perianal skin normal, no fissure fistula, no growth felt, finger fecal staining present, pale color stools, grade 1 prostomegaly was present. Systemic examination. CVS was S1, S2 was present. Respiratory system, normal vesicular breath sounds. Bilateral air entry present. Central nervous system, no focal neurological deficit. Summary: FTD old meal, known diabetic, smoker, and alcoholic, presented with painless progressive jaundice for 3 months, associated with high colored urine, clay colored stool, generalized pruritus, loss of appetite, and unintentional significant weight loss. There was no history of fever or previous abdominal surgery. Examination revealed icterus and palpable distended gallbladder. There was no palpable left supraclavicular lymphadenopathy or no evidence of ascites.
How did you measure the liver span in this patient?
Sir, by percussing from the fifth intercostal space, when I noted the dullness, it was marked, liver span was noted, sir.
You said in the mid-clavicular line, is it? But there is a gallbladder lump is there.
Yes, sir.
So how can you measure the liver span in the mid-clavicular line in this patient? Once there is a 3 to 4 centimeter gallbladder lump is there.
Yes, sir.
Which is continuous with the liver dullness. Okay. So how will you measure the liver span in the mid-clavicular line?
Sir, it will be like continuous with the mass which is
But that is what the liver span is there. No? So you have not to measure it in the mid-clavicular line. You have to shift to the anterior axillary line and
yes,
tell the liver span there, Jay.
Yes, sir.
Okay,
What was the consistency of the gallbladder lump?
It was firm, sir. Firm. It was firm, sir. It was not too hard. It was firm to hard in consistency.
Firm to hard?
Ma'am, it was not hard, ma'am. It was more than, it was just firm and...
it was smooth or it was nodular?
Yes. Sir, it was smooth, sir.
You have not given your provisional diagnosis and differential diagnosis.
Ma'am, I have given no.
Now, suppose it was a hard gallbladder lump, how will you explain jaundice in this patient?
Sir, so, in case of hard
gallbladder lump with jaundice, so what can be the cause of jaundice?
Sir, in case of, it can be due to carcinoma gallbladder. In case of any obstructive jaundice, if
what is the common presenting feature of a carcinoma gallbladder? Does it present with jaundice?
No, sir. The patient usually presents with the pain in case of carcinoma gallbladder, but in case of periambullary or CA head of pancreas, the gallbladder could be palpable. It can be due to...
When will jaundice appear in a patient of carcinoma gallbladder?
It appears in the late stage, sir. It doesn't appear in the early stage. Patient usually presents with pain, and he can also present with obstructive. He can also present with jaundice, sir. But usually it takes months.
What is the cause of this jaundice?
Sir?
Why cause of jaundice?
Usually develop in a
gallbladder malignancy. Sir is asking.
So gallbladder malignancy can grow and it can block the common bile duct and hepatic duct, sir, and can also...
Common site of common carcinoma gallbladder?
It's
in the fundal areas. Okay. So now what will be the cause of jaundice in a carcinoma gallbladder?
Obstruction.
Can it spread elsewhere?
So it can cause intrahepatic obstruction.
No. Secondarily, can it metastasize somewhere?
Yeah, it can metastasize to the second part. I mean, periambulary region, ma'am. It can cause obstruction.
Oh no.
I'm not sure.
Some lymph in some area which can compress the common hepatic duct that can cause jaundice.
Porta hepatis. There is lymph node involved.
Okay. So okay. So next question is that supposing if a patient of carcinoma gallbladder presents with jaundice, so in how much percentage of patients will this be operable? Or in all cases, a patient of gallbladder carcinoma with jaundice will be inoperable?
Mostly the patient with carcinoma gallbladder will be inoperable, sir. In early stages, the patient, we identify it if it is involving if it is in the T1, T2 stage, we can operate the patient, sir.
Yes, in approximately 30% of patients, carcinoma gallbladder with jaundice, patients can be operated.
Yes.
Okay. Well, what are the various reasons of the jaundice in carcinoma gallbladder? You have told only one or two, but there are several other reasons.
Sir, it can.
The commonest reason is, what is the commonest reason?
Porta hepatitis
Yes,
obstruction.
lymph node set of the porta hepatitis. That is the commonest reason. Then the gallbladder may directly compress over the bile duct.
Yes, sir, it can
Okay, it
cross
can
the
invade.
porta.
If it is from the neck of the gallbladder is there, it can invade also.
Yes, sir.
If there are multiple metastases in the liver is there, or there may be associated cholelithiasis in about 10% cases. Is the CA gallbladder associated with the cholelithiasis or not?
Yes, sir. It is usually it can be associated with cholelithiasis. It is
How
cholelithiasis
much?
is a risk factor.
How much approximately? 10%, 50%, 70%, 90%.
50%. I'm not sure, sir.
It's about 70%, you know? 70% of the CA gallbladder will be associated with the cholelithiasis, and 10% may be associated with the choledocholithiasis.
Okay.
Then if there is a single metastasis in the liver from the carcinoma gallbladder, can you tell that which can cause jaundice? Where will be the metastasis?
So, if it is a metastasis from the liver, it could be in the case of common bile duct or in the periampullary region, which can cause jaundice. Sir.
No, I'm asking about the liver.
Metastasis in the liver.
Single metastasis in the liver causing the jaundice.
So it can be in the segment 4 of the liver, which can cause jaundice.
It will be segment 1, caudate lobe, right? If it is at the caudate lobe is there, it can compress both the bile ducts. So if the single metastasis is there, it will be the caudate lobe.
Yes.
Okay. So how did you further go about this patient?
Sir, I would like to proceed with the investigation, sir. Lab investigation.
How can you rule out periampullary here? Why do you think it is head of the pancreas and not periampullary? Why did you give second preference?
In case of in history wise, if it is like a periampullary growth, the patient is going to present with jaundice as an initial symptom, followed by weight loss and other symptoms, ma'am. In case of CA pancreas, it is patient might initially present with loss of weight, loss of appetite, followed by jaundice and the thing.
Anything
related to carcinoma, will you get waxing and waning of jaundice?
Periampullary carcinoma, the patient will also present with waxing and waning pattern of jaundice, ma'am. They will not.
Waxing and waning occur in a periampullary carcinoma?
Sir, sorry, sir.
Why does waxing and waning of jaundice occur in a patient of periampullary carcinoma?
So there is sloughing out of the tumor cells due to necrosis. The angiogenesis factor will be like on and off, sir. So tumor cells will be sloughed out along with the blood. It will give waxing and the obstruction will be lost. So patient will have waxing and waning patterns, sir.
What else is characteristic of the jaundice in periampullary cancer?
Ma'am?
One is waxing and waning. What else is characteristic of a periampullary cancer, which is not there in head of pancreas cancer?
Initial symptoms will be like a patient will have initial of jaundice will be the presentation in periampullary, ma'am. Early
Okay, what else? What about pain?
Pain will be present in the CA head of pancreas, ma'am.
So it's a painless progressive jaundice and painful progressive jaundice. Painless is periampullary. Okay, painless and intermittent.
Okay.
And also the stool also, melena will be there in case of periampullary carcinoma. It won't be there in the carcinoma head of pancreas.
Okay. What is the name of the sign where you get clay colored stools with the melena? Silvery stools? What is the name of that sign?
Sign.
Silvery stools. Thomas sign.
So now you suspect a malignant cause for the jaundice, and it is extra
hepatic
and probably in the head of pancreas. So now you have this diagnosis. How will you evaluate? How will you proceed?
Yes, ma'am. I would like to proceed with the investigations. I would like to do complete blood count followed by liver function, renal function test, and
What will be the liver function test in an obstructive jaundice?
in case of obstructive jaundice, the liver function test, the total bilirubin will be raised and direct bilirubin will be raised, ma'am, and alkaline phosphatase level will be raised. GGT will be raised, and in case of albumin, if prothrombin time will be raised, ma'am, and deranged, and in late stages, if it is involving the liver, the albumin will also be low, ma'am.
What other thing will you like to look up in liver function test while you are evaluating this patient and planning for surgery?
I would like to check for the prothrombin time, sir, and albumin.
Apart from this, any other thing which you like to look for if you are planning this patient for surgery? Serum albumin is very important,
Yes, sir.
He told. Okay.
This will be your first investigations, Senthil?
Ma'am, sir?
Blood investigation will be the first investigation in a patient with a jaundice?
So in case of
which is the first investigation?
In case of obstructive jaundice, I would like to go with ultrasound of the abdomen as a first investigation.
So ultrasound should be the first investigation. That is the extension of the examination. Okay, so that should be the first investigation. How will you differentiate on ultrasound whether it is a medical jaundice or a surgical jaundice?
Sir,
on
in
ultrasound?
in ultrasound, the patient will the signs which points towards obstructive jaundice is dilation of intrahepatic biliary radicals. If and there will be yes, ma'am. And
only intrahepatic.
ISBRD will be dilated, and there will be obstruction in the distal CBD, or there will be a periampullary growth which can be seen if it is more than 2 centimeters.
What is the double duct sign?
Double duct sign is there is dilation of both pancreatic and common bile ducts, sir.
What is the normal diameter of the pancreatic duct?
It is 8 millimeters, sir.
8 millimeters.
8 millimeters.
Normal.
Is it CBD you're thinking? Pancreatic duct, sir, asked. It will vary.
Yes, ma'am.
What are the parts of
Only
pancreas?
up to 3 millimeters, no?
Yes.
What are the parts of pancreas?
Head, neck, uncinate process, body and tail.
So head, body and tail, it will vary. Right? What is the diameter of a normal CBD?
CBD is 6 millimeter and it can be up to 8 millimeter if it is not dilated, ma'am. If it is more than 8 millimeter, we usually suspect dilation of CBD. What
else you have to look for in the ultrasound scan apart from your extrahepatic, intrahepatic biliary radicals? What else you have to look for?
We have to look for any liver mets, ma'am. If it is present, it can be seen. And pancreatic stone can be made in.
Any other finding which you look for in ultrasound?
Other than that,
Near the porta
is present, then you will not go for CT scan.
there will be ascites, ma'am. Ascites can be made out.
Right.
Ascites and
liver mets.
Okay, now you have found there is a extrahepatic biliary dilatation. What else you will do? And high jaundice with all the clinical picture. What other investigation you want to take up? Before that, what should you do? What blood test you have to do?
I would initially do LFT and RFT. Then tumor markers should be done initially, ma'am. Then followed by
tumor markers. The RFT normal. Then you can proceed with
CCT triple phase. CCT triple phase, ma'am.
What is this pancreatic protocol? What you will see? How will you give the contrast?
I mean, usually CCT triple phase consists of non-contrast phase followed by early arterial, late arterial, normal IV. It can identify any tumor with calcification or any calculi. Followed by in arterial phase, we can identify like whichever tumor is highly vascular, like neuroendocrine tumor of pancreas and any hepatocellular tumor. In portal venous phase, we can identify the tumor in the venous phase, that is a late arterial. We can identify the tumor in the head of pancreas, ma'am. And in case of late phase, we can identify the any stricture. Yes, ma'am.
Signs of inoperability.
Ma'am, the signs of inoperability are peritoneal and liver mets, and also if portal vein and SMA involvement of more than 180 degree, we can't go for we can't go for surgery, ma'am.
So there is resectable, borderline resectable, and inoperable, right? So how do you classify? How do you define?
In case of resectable, there won't be any. There will not be presence of any mets like liver or peritoneal mets, and there will not be any involvement of blood vessels, portal vein and SM superior mesenteric vessels, ma'am. In case of borderline resectable, portal vein impingement and SMA of 180 degree can be there, and in case of unresectable, more than 180 degree involvement is present, and there is a mets, we can't resect the. We can't take the patient for surgery.
So now there are. It is resectable. How will you prepare, and what is your plan? What is the plan for this patient?
Ma'am, for this patient, if we find out the patient is the tumor is resectable, we have to optimize the patient initially, ma'am, by giving the dextrose containing fluids and correcting the electrolytes and correcting the albumin, and vitamin K supplementation has to be given. After optimizing the patient has to be taken for surgery, ma'am.
Anything you want to do? Suppose the jaundice is high.
Initially, if we are gonna prepare the patient, or we have to, PTBD stenting can be done to decrease the jaundice, to get some time for optimization.
In all patients, you will go for PTBD.
PTBD.
No, in case of if initially the patient is having any cholangitic symptom, or it will take time for us to optimize the patient, then we have to go for methods to decrease the jaundice.
Oh, with PTBD or something else?
PTBD stenting can be done, ma'am, or ERCP stenting can be done. ERCP stenting or PTBD can be done.
What is the disadvantage with the ERCP stenting? When you stent the
most common complication of ERCP stenting is pancreatitis, ma'am. It can also cause hemorrhage. Infection can be there. Patient can develop infection.
Okay, that is inevitable. Like, what else? By putting the stent?
Yes, ma'am. Stricture formation will be there in the future.
Stricture, fibrosis, inflammation, which may be cause difficulty during your surgery. So, what surgery you have in plan now?
Ma'am, initially I would like to proceed with laparotomy. Yes, ma'am.
Before you do a laparotomy, any other minimally invasive?
D-lap, ma'am. First, we have to identify whether the patient have any mets which can't be identified by radiological investigation. If at all we have any mets, then we have to abandon the surgery. If at all not there, we have to proceed with pancreatic or duodenectomy, ma'am. People's procedure.
So once you are doing a staging laparoscopy, which lymph node if positive, then you will think that it is not resectable now.
Which lymph node, sir?
Yes.
Para-aortic lymph node involvement. Any lymph node other than the peripancreatic and periport. I mean, any lymph node other than the common hepatic site. If any distal lymph node involvement like para-aortic lymph node, we have to. I'm not sure, sir. But
out of lymph node, you take it out. If it is positive, then patient is not resectable.
Okay.
Okay, sir.
So now once you are proceeding for surgery, what are the essential steps of surgery? During surgery, how will you define resectability of the patient?
So initially we have to do D-lap and see whether the patient have any mets.
Yeah, done. Mets, yes, no mets. So what are the steps 1, 2, 3, 4?
Ma'am, we have to put chevron incision and we have to go inside, ma'am. But initial step is cattle blast maneuver of taking out the right hepatic flexure, and we have to expose the duodenum. Then we have to do porturization of the duodenum. Then we have to identify the CBD. Then we have to cholecystectomy followed by pancreatectomy. Then transection of gastrectomy followed by jejunum, resection of jejunum followed by anastomosis.
What is the tunnel of love?
Ma'am, tunnel of love indicates whether the patient can be operated or not. In case of in tunnel of love, there will be a we have to find out whether the pancreas is involving the portal vein, ma'am, by passing the finger underneath it.
Portal vein or SMV?
SMV, sorry.
Okay. So what are the order of anastomosis?
Order of anastomosis is in the first we have to do pancreatico-jejunostomy followed by hepatico-jejunostomy followed by followed by jejunostomy.
What are the various methods?
Jejunostomy.
Pancreaticojejunostomy.
So gastrojejunostomy.
Yes, ma'am.
Right. Okay. So, what post-operatively, how will you manage the patient? What complications can occur?
Post-operatively, the patient has to be, the respiratory complication has to be tackled by ventilatory methods, ma'am, and we have to suspect pancreatitis.
By respiratory?
Patient has to be in ventilation for 24 hours. Because it's an abdominal extensive procedure, patient will go for atelectasis, ma'am, to prevent that for 24 hours.
No.
I'm not sure.
If you give adequate pain relief, you will not have atelectasis. Right?
Yes.
Okay. What else? Okay, pain. Next. Any other procedure you want to add for your triple anastomosis to
we can do feeding jejunostomy initially for patient to give time for healing.
Okay. Right. How will you know that there is a leak? What anastomosis can leak?
Pancreatic anastomosis is the one which is prone to leak, ma'am, and we have to check in the POD 3 and 5. We have to check for the DT amylase lipase level, ma'am.
Symptoms?
Pain, abdomen, fever, tachycardia will be there.
Suppose the DT contains blood, what do you infer?
Ma'am, hemorrhage from the anastomotic sites, ma'am. Like in
which vessel will hemorrhage commonly, and why?
What is that? It may blow out.
I'm not sure. I'm not sure.
Gastroduodenal artery. So what is the treatment for that?
Angioembolization.
Okay.
What are the various ways to tackle the pancreatic duct?
Sir, what are the various ways to
tackle the pancreatic duct?
Enter the pancreatic duct, sir.
Pancreatic duct anastomosis.
Can be done like we can do it anterior anastomosis to the stomach or posterior, ma'am. Usually we prefer anterior anastomosis because of the acidic environment. It is more preferred than posterior, and leak is less when we do it in the anterior to the stomach.
Anterior wall's anastomosis. How will you reach to the anterior wall?
It is single layer anastomosis, sir, and
no, you can do a pancreatico-jejunostomy or you can do a pancreatico-gastrostomy.
Yes, sir.
No, these are two important ways, and then there are various ways to do the pancreaticojejunostomy, like mucosa to mucosa, Duncan type technique. There are different types of techniques are there. So is there any difference between a pancreaticogastrostomy and pancreaticojejunostomy?
Yes, sir, but I'm not.
Can you tell which pancreas is more likely to leak? You have done the anastomosis. Which one is more likely to leak?
Pancreaticojejunostomy is more likely to leak than gastric anastomosis.
What are the pancreatic characteristics of the pancreas which is likely to leak?
Ma'am, because of pancreatic secretion, which is, ma'am, I'm not sure.
If it is a normal
soft
pancreas is there and a pancreas of pancreatitis, which will leak more?
I'm not
A
able to
normal
get
supple pancreas is there, or
Yes, sir.
a fibrotic pancreas of the pancreatitis. Which one will
Fibrotic,
leak?
fibrotic with pancreatitis will leak most.
No, that will not leak. The supple pancreas will leak. The
Okay,
normal pancreas that will leak as compared to the fibrotic one. And then the diameter of the pancreatic duct which is there. If a small diameter is there, it's more likely to leak. If it's a big diameter is there, less likely to leak. So these are the two most important things. What is the texture of the pancreas and what is the diameter of the pancreatic duct?
Okay, sir.
How do you define the pancreatic fistula?
Ma'am, sorry, sir.
How do you define the pancreatic fistula? When do you say the patient has a pancreatic fistula?
That's something to measure in the drain.
He has already told.
Rule of three.
Sorry, to measure amylase lipase in the veins.
Rule of three. Tell that. That's what sir is asking. On day three, you've already told.
Yes, sir. POD3, if the amylase lipase level in the brain is more than 3 times the normal, then we have to suspect pancreatic fistula.
There is a more than 300 ml.
Yes.
Fluid is there.
Fluid.
Okay. What do you do to prevent delayed gastric emptying?
Ma'am, to prevent gastric emptying.
Delayed gastric emptying. What do you do to prevent that? What is the modification of Whipple's you can do?
Pylorus preserving surgery can be done in case of to prevent gastric to delay the gastric emptying. 2 centimeter from the pylorus, we can dissect if it is.
What is the name of the surgery?
Pylorus preserving surgery. No?
Does it have a name?
I don't know.
Long maze.
What are the various palliative options for the carcinoma head of pancreas?
Sir, we can do if it is a malignant, we can't avoid the patient. We can go for metallic stenting, sir. There are 3 types, there are covered stenting, partially covered, and uncovered stenting, sir. So
what
we
are
can.
the things you want to palliate in a patient with a carcinoma head of pancreas?
So we can go for triple anastomosis, sir. For that, we have to
Patient is
decrease the jaundice.
jaundiced.
Yes. We have to decrease the jaundice. For that, we have to we can go for PTBD and stenting and gastrojejunostomy and choledochojejunostomy can be done.
What is
what
the
about
survival?
pain palliation?
Ma'am, sorry,
Pain palliation.
celiac access block with absolute alcohol can be done, and the splanchnic plexus block can be done.
What is the survival rate of after Whipple's?
It is more than 25%, and the mortality is less than 2% in experienced and ma'am, but survival rate is 54 months. Survival rate is less than 18 months, ma'am.
What is there any role of chemotherapy after
Yes, ma'am.
surgery, and when will you add it?
Sir, in Usually after surgery, we go for chemotherapy, sir. And in inoperable patient, we will go for chemotherapy, sir. And we'll give fall.
Patients?
Sir?
Which chemotherapeutic agents can be used?
Capecitabine, gemcitabine with paclitaxel can be used, sir. If you give for 6 months, it has a it can prevent morbidity for around 54 months, sir. If we add if you have capecitabine and all, there is a chance of remission, a bit remission, not fully. Paclitaxel can be added, sir.
How will you manage stricture of a hepatocogenostomy?
Ma'am, like placing stent, ma'am.
How? Which route?
10, ma'am, ERCP stenting, 10 fins, size of 10 fins.
So you have to do PTBD, proximal. Right.
What is the cause of hepatorenal shutdown in the patients with the obstructive jaundice?
Sir, in case of obstructive jaundice, the renal load of bile salt and bile acid will be more, sir. So it is going to damage the nephron. So kidney will go for failure, sir.
But what are the important factors? There are main two important factors which are there, which you have to take care.
The kidney is going to absorb more fluids, and because of the bile damage, the nephrons is going to be damaged, sir. So for that, we have to hydrate the patient. We have to decrease the jaundice to titrate it, sir.
Main is endotoxemia. So you have to take care of endotoxemia, and second is the hypotension. So both these things, that's why you give the patient the prophylactic antibiotics, and you take care that during the operation, the patient doesn't go into the hypotension. So these are the two things which precipitate the hepatorenal shutdown.
Kanagavel, sir? I think it's...
We can ask Dr. Kanagavel too.
Madam, maybe we can ask the student to ask any doubts if he has, ma'am. Then we can close, ma'am.
Anything that you have not followed, or he has answered almost all the questions. Yes. And he's nicely said, I don't
student
know.
of Madras Medical College, ma'am.
Very nice.
He has done quite well.
Very well.
Yes, Senthil, your presentation is very good and you have answered almost all the questions well. There's just one thing I would like to add on. If you don't mind, can you go back to your summary slide?
Yes, ma'am. Sorry, ma'am.
One small thing I wanted to point out. There, I think you have mentioned. Is it coming out? The summary part? I think the slide.
Summary.
Slide before that. Yes. Here you are. See, you have said that the patient is. Where was it? I saw it. That is, he is an alcoholic, right? Somewhere you have written it. Yes, smoker and alcoholic. May I request you not to use that term because it is not nice. And alcoholic you use only in certain specific areas, okay? So you can say he is maybe addicted to taking so much alcohol, but don't use that term. The second thing is that when you're talking about your, I think when you talked about the examination part, you were showing the lump, abdominal lump. It was quite small as far as I could see. And when you put it in the diagram, I think it was quite large. Again, when you were talking about movement with respiration and movement of the lump as a whole. So movement with respiration, you have to be specific. You're talking about the movement of the lump Whereas when you're talking about mobility of the lump, those are two different things. Please don't mix them up. Those are the things that had just caught my eye, so I thought I'd just tell them to you before we conclude. I hope you have understood the points.
Yes, ma'am.
Yes, that's all from me.
Thank you, Kanagavil sir, for involving me in this wonderful presentation
madam.
and academic activity.
Thank you, madam. Thank you.
Yes, sir.
And thank you, Jishan ma'am, Kanna sir. I could see Vaibhav sir still staying connected. Muthukumar sir, Malar ma'am, and thank you one and all. Thank you both the students, Sanket and Sendel, for making this evening possible. Bhaskar sir, I would request further contribution from your upcoming classes also. Thank you very much. And Kanna sir, any other comments, sir? Can we call a close, sir?
Yeah, I think we can. He has done the good job, yeah.
Vaibhav sir, anyone else to give a comment, Muthu sir?
No, sir. Thank you, sir. Nice presentation.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you,
Thank you, sir.
Thank you.